of our Healthy Brain webinar series. Today's presentation is titled Applying Findings from a Longitudinal Study of Dementia Care Group Homes to the Development of Community Dementia Support Services for Adults with Intellectual Disability. A little bit of housekeeping. Healthy Brain webinar series is presented by the HealthMatters program, and we're located at the University of Illinois at Chicago in partnership with National Task Group on Intellectual Disabilities and Dementia Practices. And the funding is provided by the Centers for Disease Control and Prevention, National Center for Chronic Disease Prevention and Health Promotion, the Healthy Brain Initiative Award. CEUs are not offered for the webinars. Each live webinar will be recorded and available to view on YouTube with resources to download or view online. So we will let everyone know after the webinar once we archive the webinar, and it's usually within a week. We post it on our YouTube channel. Today we have 45 minutes of presentation with about 15 minutes of question and answer. We have a large group, so please use chat box for comments and questions. I will wait for to ask or use your comments at the end of the presentation. I wanted to introduce the two presenters, Dr. Matthew Janeke, who is a research associate professor in the Department of Disability and Human Development at the University of Illinois at Chicago, as well as the co-president of the U.S. National Task Group on Intellectual Disabilities and Dementia Practices. He's also a member of the Federal NAPA Advisory Council on Alzheimer's Research, Care, and Services. The second presenter is Kathy Service. Kathy has worked in the field of intellectual and developmental disabilities since 1976, both in institutional and community settings with the Massachusetts Department of Developmental Services until her retirement in 2016. And now she continues to consult in dementia matters. She has served in the initial steering committee and is currently on the board of directors of the National Task Group on Dementia and Intellectual Disabilities, and as a master trainer contributed to the NTG Dementia-capable curriculum. Welcome, and take it away, Matt.
Thank you very much, Yasmina. Kathy and I are going to double team this presentation, so I'm going to start first. Kathy will follow. I also want to draw your attention to the slides that we're going to be presenting. You'll be getting copies if you don't have access to them already, and there's a lot of detail on those slides. So we won't be covering a lot of detail. We'll be covering some of the findings and informational bits, but we request that you go back to the slides afterwards and kind of ground yourself in what the information covers. My topic is going to be looking at the background of dementia and how do we use a group home model to care for people who have intellectual disabilities and dementia. And, the first question really is, why is this something to think about? And, dementia is an issue. It's a result of a brain disease or injury such as Alzheimer's disease or some other diseases like Lewy body or a brain injury and trauma. And what happens is that when people get older and they perhaps get diagnosed with dementia, they're at least able to care for themselves and require supervision and someone to help them with their basic necessities. This becomes an issue for us as if we're providing services in terms of how to provide supports or augment supports or alter supports for people that are already in some kind of situation, whether it's home or community-based care. So dealing with dementia calls upon agencies to make some critical decisions about dementia care and developing support services. Now, the main thing to know here is the difference between Alzheimer's disease and dementia. You'll hear these two terms used interchangeably. Alzheimer's disease is the disease of the brain that leads to dementia. Dementia are the behavioral factors, the expressions of change in the memory and other factors in a person's functioning. So dementia is the behavioral piece, Alzheimer's is the brain disease. So some things to know about dementia. Basically, dementia is an umbrella term that really kind of captures a lot of different things that affect people as they grow older when they are affected by brain disease or injury. And a lot of people who have Down syndrome are at risk of Alzheimer's disease itself and consequently do develop dementia. But other people who have other types of intellectual disabilities have the same risk as the general population. In most cases, the average onset in people with Down syndrome is about 52, 53 or so. And it's in the 60s and 70s for people with other types of intellectual disabilities. Recognize also that Alzheimer's disease begins some 20 years before onset, which is when you begin to recognize the signs and symptoms of dementia. The major changes include things like changes in memory and oftentimes changes in personality, which also signal dementia in people with Down syndrome. I'm going to go over to the next slide here and give you some quick wrap-up of the dementia warning signs, some things you may be familiar with. You'll see these in the general population brochures. It includes things like unexpected memory loss, difficulty doing usual tasks, getting lost or misdirected, being confused in familiar situations, experiencing personality changes, having problems with walking, ambulation, gait, and the onset of new seizures oftentimes. These warning signs are the same things that apply to people with intellectual disabilities. Different types of dementias can influence treatment, and this is a factor in both in group home care and other types of care. Alzheimer's disease is an insidious disease. It's a linear, it basically leads to a slow progressive decline of function and loss of cognitibility. So you have some time to deal with it. Vascular dementia oftentimes is abrupt, and it will affect certain parts of the brain, and it may be the cause of an accident like a stroke, something like that. And so you will have a little different factor in terms of providing care and recognizing when it's occurring. And another disease called it's resulting in dementia is the frontotemporal disease. And this will affect behavior and personality, then eventually all function. So knowing what's useful, knowing what type is used, the type of dementia is useful in terms of determining the course of treatment, and also determining the best ways to handle challenging behaviors, which may be present in some of these dementias and not in others, and help with organizing care staffing patterns and clinical supports. So those are some features that it's good to consider and in terms of what you do in terms of treatment. Just to kind of give you a summary of some of the key findings that we know about dementia and intellectual disabilities. I mentioned before, the rate of occurrence basically is that a lot of people, in terms of about maybe 60 to 90% of individuals with Down syndrome, when they get after 50, will have the signs and symptoms of Alzheimer's disease, which is the dementia. There's a higher prevalence of it, and most of the time when you see Alzheimer's disease, it's in adults with Down syndrome. Other types of causes of dementia are found in people with intellectual disabilities in general, like it is in the general population. The risk factors include Down syndrome and head trauma. Onset, as I mentioned before, average age of onset is early 50s for Down syndrome, late 60s, 70s for others. And usually most dementia that's related to Alzheimer's disease and people with Down syndrome is diagnosed within 3 years of onset. So it's a progressive disease, but it's a quick progression in Down syndrome. In behavioral changes, you'll see changes in personality more evident in people with Down syndrome. More memory loss is evident in other types of ID. Neurological signs, late onset seizures are a clinical sign of Alzheimer's disease. Generally in people with Down syndrome, it's an indicator that the disease has progressed. Usually life expectancy after recognizing that people have late onset seizures is less than 2 years. And then duration. There's an aggressive form of Alzheimer's disease and Down syndrome that can lead to debilitation and death within 2 years of onset, but in most cases it runs about 5 to 7 years. With people with intellectual disabilities, the duration is usually like the general population. It can go anywhere from 5 to 20 years. Some things to consider in terms of timing. Signs and symptoms. Kathy's going to get a little bit more into the signs and symptoms of staging, but I just wanted to let you know in Alzheimer's disease, we look at usually at 3 stages: early stage, middle stage, and late stage. And when you're constructing services, early stage is something that you can also just augment in terms of where the person is. By the time the person reaches middle or late stage, they probably would need some specialized housing or specialized supports that they cannot live by themselves. I'm going to skip over the rest of this because Kathy is going to cover it. Some of the key aspects of dementia presence to consider when planning housing. The first thing is onset, obviously. When is it going to occur? And we're going to cover a little bit about that in terms of the data we found from our study. We mentioned also the early onset dementia in people with Down syndrome about mid-early 50s. The progression usually is with Down syndrome is some quick losses, other more normative changes in personality before memory. And for ID, it's varied trajectories. It could lead to progressive decline or a slow decline or a fast decline. And then duration, how long the people are affected, another consideration that we have to worry about. So factors to consider with housing and care planning. The onset one is really the one. What do we mean by onset? Onset is speculative. It really means it's the time when we identify a point when some significant change or impairment has become noticeable in an individual. It's not necessarily a thing you can measure, but you can observe and report. And as I said before, usually in the 50s is something you begin to see in Down syndrome. That little chart below that age of onset shows the difference between the yellow bars and the green bars. Yellow bars are people with Down syndrome. You can see a high prevalence of dementia in early late stage age in people with Down syndrome, and a kind of a more progressive distribution in people with intellectual disabilities. Trajectory is another thing. There's a lot of variability in terms of how people progress when they're affected by dementia or brain disease that leads to dementia. And you can see different durations, types of dementia it may be affected, health status and coincident conditions may affect it. The chart there shows an example of different trajectories. This is how long people may be living and declining with dementia. So some people may decline very quickly and have a very short duration of the disease and eventually die from it. Some people may linger for a very long time and have a very slow trajectory. So we talked a little bit about onset being important. Let's give you kind of a heads up for surveillance. If you know that the 50s are usually a point where people start to have changes if they have Down syndrome, this is when you start looking for changes. You start developing some baseline measures. You start recording information, introducing periodic screening to do that. And staff have become much more watchful to look for some of the things that a person may experience. It provides a sort of an index of suspicion. And it helps us to reformulate services and care practices. We're creating safer environments, for example, if someone's being affected, signaling change in demands or daily efforts, and planning ahead for eventualities. These are the kinds of things that we have to think about in terms of we develop programs. Some of the expectations of change, and you can kind of look into this later on in terms of the slide, but I just wanted to quickly tell you some of the associated factors in terms of extenuating these issues. The coincident conditions may affect gait, which is walking, movement, ambulation, balance, sensory faculties, and cognition. There may be also comorbidities, other illnesses or diseases that may affect the physiological processes and functions of the individual. There may be previously identified mental health issues. People may have a mental health issue that is coming into older age and it's on top of dementia, or dementia is now on top of that. And then there may be the issues of late onset seizures. In people with Down syndrome, you see the effects of precocious aging, which is early aging, usually in the late 40s, 50s. And people have expressive language difficulties. They can't verbalize things as they used to. They may have experienced nutritional deficiencies and diet inadequacies. And you have to look at the presence of polypharmacy. Are any of those medications that people are on, multiple medications, affecting behavior and change? What are some of the options for providing care for people with dementia? It's two basic things: staying in place or leaving the place that you're living in. In most cases, people may be living at home with their families, or they're living with mates, or living in group homes, living in some other kind of setting. And this kind of draws upon how do you provide supports in those settings? And the considerations might be home adaptation, most closer supervision for safety and avoiding self-harm and neglect, and possible wheelchair use if the person begins to have difficulty walking, palliative and hospice aid when person begins to have advanced dementia. And certainly, the event and agency focus will include things like outreach and supports, which is the HCPS waiver program services, and helping family caregivers in terms of providing advanced care and adapted care in the home. Now, if the option is for leaving the home, in most cases in the general population, the main option is nursing care. But in the ID field, we do have some other options. And this includes group home care. And one of the things that would happen here is that you could have an agency specially run dementia care group home program. And that is much more productive because you're looking at a small number of individuals receiving specialized care as opposed to a large facility, which cares for maybe hundreds of people, and the person with ID or Down syndrome gets get lost in the shuffle there. There may be other options for day services or other services like that, like memory care centers, assisted living programs, but these tend to be expensive and may often be not affordable if a person's on Medicaid. So the model that is emerging in terms of group home-based dementia care, the variations are two. Edging in place, which is using a single home where a person is diagnosed with dementia, perhaps like they would be diagnosed with cardiovascular disease or some other condition, and they just stay in their own home and you provide the supports built around that person. It's like wraparound services. And it tracks the person from early identification of dementia to mid second and then late stage of dementia. And the person's there until perhaps they die, or they have to find some replacement because the home may not be able to provide for terminal care. But that's the basic theory there. Now, in place progression is when you have multiple homes, and you may start with a home that's providing supports like the one in Aging in Place, and then people may move to more specialized homes where you have individuals who have they're more adapted at this point, they're more ambulatory, they're still functional, and they might be sort of like mid-level care. And then they move to a second home, which has more advanced care, where people start to decline and maybe need specialized supports and services, more skilled care. The third option, and this is the one that we've been following as a part of the last study we've been doing, is 3 homes. And you go from the early stage to the mid stage to the late stage. And each home is specialized. And it's specialized because the staff have been trained to provide specialty care. It's specialized because perhaps the internal design of the home is a little different. It's specialized because there may be other services that kick in for people who are in the early stages as opposed to late stages and vice versa. So that's sort of the model that is starting to emerge now in many agencies. So the study that we've been taking, this has been going on for about 10 years now. It's happening in the Midwest in a large agency, and they developed 3 homes on the same lot in the community. And each home is 5 individuals. That's the basic thing. We started the study back in 2011, and what we call is the 15 legacy adults. Those are the 15 individuals who first were living in the homes in 2011. There were 5 persons per home. Subsequent to that, we're now also studying 15 replacement individuals because some of those people have died or moved out, or they've been replaced in one way or another. And so these are 3 purpose-built, 5 resident dementia-capable group homes. And then we're also studying 15 community-dwelling adults who do not have dementia as age-matched controls. And we've collected a lot of different issues of information, such as demographics, functional, resident function, health, other related information. But what we're going to be covering today is just some of the key findings that will help you plan group home care. What have we found? And I've broken this down into 5 areas: the admission trends, length of stay, mortality, care patterns, and staffing. These are the kind of things that may be integral to planning for a residential environment. One is the admission age clusters. Over the years, we've discovered that as people get referred in and originally placed in the homes and then referred in as replacements, they kind of fall into 3 clusters in age. The first cluster is on the average people who are about 50 years of age. Second cluster, on the average, people who have age about 57. And the third cluster is age about 67. And they vary to some degree. The younger people tend to be generally people with Down syndrome because of the early onset issues and recognition of need. And then in the second grouping, there's kind of a mix between Down syndrome and intellectual disability. And the third cluster are usually people with intellectual disability who are identified earlier or later in age, and consequently may often be seeking out special dementia care in a group home after they've advanced quite well in dementia. There were a couple of people that were older, they were in their late 70s, and much younger, some people in early 40s. But these are the clusters that have came out of the looking at the patterns of individuals who are admitted. And you can see from the graph there, that is an upward sweep, obviously, in age. So people are aging in place. What's the length of stay patterns? This is consideration in terms of how long people will be in the homes in terms of planning purposes. This is the busy chart, but I just explain what it is. The darker color is 3 homes. So there's the red home, the green home, and the purple home. I'll use that for an easy way of covering it. The dark color are those individuals with intellectual disabilities. The lighter color are people with Down syndrome. So you can look at that and compare, who's Down syndrome, who isn't. The length, the bars that show under each of those 11 years or so is how long the people have been in the home. Right now, we have 4 survivors of the 15. Over the 10 years, the average length of stay in the 3 group homes is about 4.9 years, almost 5 years, once they go in, and maybe before perhaps they die. In most cases, individuals have died either in the homes or very close to death and going to a specialty skilled nursing home, maybe just very close to death. So they live most of the time in those homes. The average length of stay for the 15 individuals who started out was about 8.3 years. So as people died out and they were replaced, they sometimes were replaced by individuals who didn't stay very long. And you can see some of those bars that are in the middle of the chart or toward the end of the chart, they're only there for short periods. And that means they entered and then they lived only about for 2 or 3 years and they died. The last row, the last column in there are people that are now still there as we're tracking them. And you can see in the purple chart on the right-hand side, there are some who have just entered in the last year, and we'll be tracking those as well. So the implications here is that home compositions may change over time as people progress more through the disease, through the trajectory of the decline. And it's something to consider as you think about the homes. And it doesn't mean that you have to have the homes ideal in terms of the coherence of the individuals, but it does mean that you may want to do some pattern adjustments as you see people changing in their function skills. What about the death rates, the mortality rates? The original residents were 15. The survivors right now are 4. 27% of the original 15 are still alive. 73 have died over the 10 years. The mean age at entry when these 15 entered was 59.1 years. And that differed in terms of intellectual disability, 66 years, and Down syndrome, 53 years. The mean age at death was about 67.5 years. People with Down syndrome who died at the average of 58, almost 59 years of age, and people with ID at 72 years of age. A little bit of a difference between the males and females. Males died a little 3 years earlier than females. The mean age from entry to death was about 5.4 years. So again, planning purposes in terms of replacement, how many people are going to be on a waiting list that may be looking for replacement in the homes. You're thinking about, on the average, when people die at 5.4 years, there'll be replacement possibilities. The mean age of entry of the original residents who died was 60. And the survivors was 54.4. And the deaths began 2 years after admission. Now, interestingly enough, when we compare the controls, again, those individuals who did not have dementia, the 15 that we're following, 5 have died, and the average age of their death was 71.4 years. So you can see the difference. They are surviving much longer, and the dementia is obviously having an effect on the rate of mortality of individuals in the homes. Okay, one more slide here in terms of the mean age of residents. This is, again, showing you the trajectory of the residents and the kind of fluctuating ages that may be in the home. What happens at the beginning, they kind of all start out at different ages and they move to the right. If you look at that dotted line, it's sort of an age trajectory. They move upward. Now, as people die, they're oftentimes replaced by younger people, and that drops down the mean age for homes, and it fluctuates. In the end, as you can see, after 11 years, they're sort of all converging again after the major changeover of individuals. So think about this. The long-term residence and age in place and mean age of residents progressively rises as a factor. And as new entry residents, if younger, lead to lower mean age, but eventually also show aging in place. So the implications are with aging, comorbidities increase need for health and medical care. All right, quickly on staff patterns. This is just a quick chart. You can study this when you take a look at it. What we wanted to do is find out how many hours are given to staff care of individuals in 3 homes. And this is just an illustration of how it varies over a day. This is a pattern over a day. And what happens is you get low services needed in early morning or overnight, but high intensity services during various parts of the day, depending on the nature of the individuals in the homes. And they fluctuate over what period of the day between those 2 vertical lines that you see up there. The most of the time is spent on toileting aid, eating, drinking assistance, the personal care kinds of things, and also behavior management. So this is something to also consider in terms of staff patterns and how patterns may change based on the nature of the individuals who are in the homes. And then how many staff range? Oh, this particular program had 3 homes. One home was advanced dementia home. There's the group home number 3. The mean staffing was 4.3 full-time staff and 2.3 part-time staff. So the implication here is consider staffing patterns at the homes. You need more staff during times when at peak activities in care. You need specialized staff, and you have to plan for turnovers. So the findings basically are these. Of the 15 legacy residents, 11 have died so far and were replaced by 15 others. Greater mortality was noted among legacy residents. than with ID compared to Down syndrome. And Down syndrome folks were more surviving. All 30 residents, the legacy and replacements, exhibited features related to decline, such as increasing problems, more comorbidities with age, and lessening function and dementia progression. With multiple homes over time, there were in-home transfers and new admissions, so you have to consider that as well. And basically, there's an ebb and flow of movement related to the stages of dementia and changes in character among the 3 homes, as well as variations in staffing patterns and periods of focused care staff and intensity during the day. And obviously, the costs and staffing patterns varied among the 3. I'm going to skip over this because I'm in the interest of time. I'm running over it. So I want to give you some things to think about in terms of creating a dementia residence. One is the building set up for dementia care? Is it single level? The lighting is such that it's adapted for dementia care, barrier free? Is there a yard for walking and wandering? Have staff received specialized training? At what point does the agency admit, for example, to the home? What are the criteria? Is there a matching to level of other residents in the home? At what point does an agency perhaps terminate care? In other words, when do they discharge someone? What are the policies, end of life options? Or they retain the person until the person dies? How is the daily support program individualized? Is there involvement in the community? How is it adapted to change in function? How long do people stay at the home and are adaptable for advanced dementia? And what are the attitudes and capabilities of staff? Are they accepting of dementia? They recognize what it is? Are they comfortable with it? Are they comfortable with the skills they have? And again, what are the training and clinical supports that could help them? And the last thoughts on this is dementia care expectations. Consider the varied trajectories of decline, because that will affect the nature of the homes. That will change over time in terms of characteristics. Mortality is linked to complexity of pre-existing conditions and progression of dementia. The changes in focus of care needs over time, including advanced dementia end-of-life care. So the point being is effective in-community dementia care is contingent on understanding what dementia does to behavior and function, how well staff are trained, and how agencies provide support, such as clinicians who can consult on care issues, help with planning when changes occur, and staffing levels based on needs for care. Okay, and just quickly, if you're interested in some documents that are in terms of guidelines for caring, these are located on our website, the NTG website, www.the-ntg.org. You're welcome to get those. You can download them. They're available to you. And this is my contact information if you need it. And our Wichita Project, which is the study I just talked about, is located on our website. You can resource it there. I'm going to now turn this over to my colleague, Kathy Service, and let her carry on.
The things I want to start out in saying that a guiding principle for all of us is that people are living, note that, living with dementia. And life, we're trying to make life as meaningful, comfortable, engaged, and connected as possible. So I think I would like you to kind of look at these old, this is kind of dated. This is from the WHO in 2002, the principles for supporting people. And these are as fresh and current as today, looking at any of these principles. And you'll see some of the notions here, such as communication, getting information, promoting independence, preventing excess disability, and relationships are still, there will be threads that go throughout what I talk about. Okay, so some of the guiding principles, and this is some themes that I'm going to be talking about. And I'll start first with the lifespan. We need to use the lens of a lifespan because dementia starts probably well before we see the symptoms. And we know this, and there's a lot of actions that we can do that can mitigate or even prevent dementia. And in fact, the Lancet had in 2020 had an article talking about, in that article, they talked about that modifying 12 risk factors might prevent or delay the onset up to 40% of dementia. So, but that's, we're talking right now after the person has been diagnosed with dementia. So the next concept that I like to look at, and I really stress here, is well-being. I think well-being in all realms, bio, psycho, social, and now ecological, because that will help to prevent, minimize distressing behaviors and more of a rapid demise. Then I look at person-centered and relationship-centered care. And we all know that there's an intersection among all of us, and how we connect, providing that connection, and when the neural connections are somewhat fray will matter, will contribute to a person's positive life living with dementia. And lastly, we can use the life story from the past and who this person are, the essence of who they are, and as we are in the present moment, we need to be present with that person as we provide care and support. And then as we look to plan for the future, both long-term and short-term. So actually, this is interesting because as Matt was talking, looking at his slides, talking about the interventions, and he pointedly brought out from his studies about the value of education and planning. The other thing that I wanted to add here is dementia is not an acute disease. So we need to pause and plan and with caring after being informed. So these are the kinds of concepts that Matt talks about, and that will also help us as we talk about supporting people practically through the disease. So talking about planning, and often I'll hear about a lot of calamitous situations, and then when you really think about it and dissect them and think backwards, there were a lot of things that could have been done beforehand to prevent something for that from happening. So I try to remember that planning is the development of goals. What are the goals here? Where is the person, and how can we care and all work together and support that person? And then looking about decisions. For instance, who is the person? And depending on where the person is in the disease process, what about supported decision making? And how can this be informed by the person's life story? Remember, people are always changing and dynamic, so our plans might change, and context does matter. So then we can look at relationships, the relationships with staff, family, peers, and what we need. And then how do we all gather this all together, looking at the 3 C's? And this comes from Kathy Sursick-Storr, who had a brother with Down syndrome and Alzheimer's disease, and was part of the National Down Syndrome Society, the Aging and Down Syndrome guidebook. And she talks about collaboration, communication, and coordination. We all need to do all of those things. So it's quite a dance we have to do. So my next slide here. So I am going to use terms of the, I can't help but looking at stress the need and benefit that to operationalize the concepts of for well-being is using the 6 pillars of brain health. And I'm going to use those to help organize the clinical and care practices. And this comes from a number of years, as you know, of working and supporting people. And I had the first chance I had, or opportunity that I had, somebody with Down syndrome and Alzheimer's disease was back in 1995. So, and I knew nothing. So, becoming informed helped me with the planning. So you're going to be listening about some of the things I learned over this time. So let's start first with nutrition, a topic that's near and dear. And we're not going to get into a lot of the details about what are good, sound nutritional practices, because you've had that in other webinars, and there's information out there from the NTG, and we can also we're going to be developing other resources for you. But let's talk about that. And one of the things is that people with dementia are high risk for having malnutrition and weight loss. And weight loss of greater than 5%, say over 6 months. But I would also just kind of maybe even depending on what the person's size to begin with, maybe of concern. So looking at what can we do? How do we notice these things? I mean, looking at the person's preferences. Routines are key. Keeping the meals, having routine time for meals, giving, that routine gives the person a trust in the environment. And that's really important in terms of stabilizing the person. You may have, because people may not be able to eat, having periods for grazing throughout the day, but keeping track of these kinds of things. Remembering people can't express hunger and thirst, and that's essential in terms of preventing dehydration. And that's a real issue that we find a lot for people with dementia is dehydration. So, offering fluids at times are really key for people. Looking at appetite, what the person's appetite, trying to find foods, if their preferences, knowing their life story, knowing things, what's essential that they've always had, helping those kinds of things. And one of the things that I find an encouraging intake with the person is that I have to tell you all who are out there who work in group home settings that you have a lot of skill sets just based upon your work supporting people with intellectual disabilities who may have lifelong disabilities around, preventing distractions at meal times, using different kinds of adaptive equipment, such as sippy cups, plates with high edge, like the edge part of plates, all of those things. The couple things that you may not know about helping the person to prevent disability, you can jumpstart a person to eat. For instance, helping them bring the food up to their mouths, tasting it, and maybe that will get them to continue to eat. That rote memory will kick in place. So there are a lot of techniques and interventions you can do to prevent excess disability and help encourage the person to eat. There's also things around watching the person's oral situation, looking at if the person has dysphagia. Dysphagia happens with dementia for a lot of reasons. With regards to not remembering to chew, you might have to remind the person to chew, etc. So I think if, looking at the person's mouth, making sure there's not, a pain in the mouth, that's why they're not eating, or the medications. Some medicines can be very drying. So looking at those kinds of things. The other thing is in terms of when you're helping the person eat themselves, it's fascinating. If you haven't done this, one of the exercises I would advise everybody to do is practice feeding each other. The pacing and, putting, when you're feeding somebody, what does that feel like to somebody? So this might be giving you a better empathy for in the activity when you're working with a person to eat. So the other thing is in terms of looking at constipation, and of course, as a nurse, I'm like, oh God, but that can be it can cause a person to stop eating and make them uncomfortable. So there's a lot of things that I think we can do in terms of, for the person. Also, as people develop more and more dysphasias, like getting OT and speech consults and figuring out textures and consistencies and what works best for the person, and developing, how to, whether you need oral supplements, etc. But I think there's a lot of things for us all to kind of consider for the person to encourage them to eat. And lastly, for your houses is like, and I put this at the end, keeping track of the GI tract. Record these things, keeping track. If you see the person's not eating, writing things down for yourself. This will help you to kind of figure out where the issues are, what's going on, if it's foods and stuff. And I just want to backtrack. I learned so much from the OTs and the speech people around eating. For instance, you might encourage somebody, stimulate somebody to eat by offering one bite to be hot, next bite to be cold. There's a lot of techniques that people have. So I wanted to make sure that you have a lot of resources and taking advantage of. So, and here's some resources about eating healthy. But the other point that I wanted to point out here, and this is a great guide I found from the UK about eating well for older people and older people with dementia, practical. So you can get that down and download that online. And the stay tuned part is about some of the resources that we're developing through this grant. Okay, next slide, please. Okay, exercise and movement. And it goes without saying is that on the left, I'm not going to get into the benefits. There are so many benefits of moving about. And they also could contribute to communication and reduce wandering. So how can we do it? Let's figuring out ways, and I'm not going to read these all, but one thing, looking into your environment, figure out if you have pathways, checking in terms of, do you have sharp edges if the person falls? Falls can be detrimental. What do you need in terms of preventing falls and having the person, if you have a yard that is fenced in, to have person to be able to wander through the yard, having places, that the person in a yard, like little tables with food for the person, make it enjoyable. One of the things I was thinking about visiting a lot of houses is ways to encourage a movement is music and dancing. These are kinds of things, and there are people that ability to try to dance. If people can dance, I've been encouraging that, dancing your way to the bathroom in terms of making things fun for people. Put on Michael Jackson or Elvis Presley, whatever tunes people like to listen to, and having those kinds of tunes to help guide your fun times moving together. And I'd be remiss if I don't talk about wandering, because wandering can be a dangerous situation. And so looking at, how can we prevent, and what does wandering mean? I mean, there's a lot in the literature right now about wandering and whether or not you need to stop it or whatever, and I'm not going to get into it, but there are a lot of things proactively that you can do with the environment and short of surveillance around wandering. So I'm going to zip through this pretty quickly. Sleep and relaxation, we're having somebody come and talk about sleep and relaxation in one of our future webinars, so I'm not going to get into that, but it really is important. Sleep hygiene and routine, even on the weekends, is key. That will help to kind of hopefully restore some of the circadian rhythms. We know that older people have our sleep patterns are changes naturally with age, and there are a lot of things you can do. I'm not going to read them all out here. The one thing I do want to highlight is the prescribed pain medicines, that if you have somebody who has arthritis, by all means, I would offer, give them their Tylenol before they go to bed. Also, check out the beds. Maybe the mattresses aren't as comfortable as we like to think they are. So there's a number of things. The SAD light, thank you, my friend from Canada who made that suggestion to me. That might help to modify circadian rhythm. So, and then mental stimulation. What can we do? People may be more inclined to participate around social aspects, making it fun, etc. So capitalize on the senses, depending on where people are, using sensory motor, smell, music, taste, etc., in terms of mental stimulation. And that guidebook, the Down syndrome guidebook, has a lot of activities that you can do to support people and have around mental stimulation in terms of when they are in terms of keeping them engaged. Medical health is important, and depending, again, having a conversation with the healthcare providers, having communication amongst the healthcare providers, depending on, you're not, unfortunately, or whatever, direct care, people are working in the house are not the decision makers. So developing that relationship with the decision makers. Again, one of the things, keeping up with vaccinations, just as an example, shingles can be very painful. So we know about that. We can understand that. What would it be like with somebody with dementia to get shingles? So I think we have to kind of be proactive in our approach. Again, around communication, transitioning, making sure that people there's communication between the sending and the receiver, and yourselves, usually Friday afternoon that you're getting discharged from the hospital, you can request that this is an unsafe discharge, because most hospitals will not want a person to be readmitted back in terms of payment. So, have a discussion about these things. The other things with falls, it's essential that you keep track. If people fall, really, it's like having really record, use your ABCs. Antecedent, what happens then, and what happens after the fall in terms of documentation, because that will tell us as healthcare providers what the cause of the fall is. And again, managing diseases, is going to be key for all of us. Whatever chronic diseases people have, their reflux doesn't go away just because they have dementia. So treating these accordingly. Delirium is a really important thing to remember. Delirium is the sudden onset of confusion, and often as a result of many factors. And in fact, early on in the COVID, when COVID first surfaced, many older people went to the ER with delirium, and the main factor, the issue was that they had COVID. And in the geriatric literature, that was a high something to really watch out with when we talked about delirium. And we can look at all of these, and what can we do with any of these things, or the risk factors in terms of sensory impairment, pain, the polypharmacy, etc. And again, hospitalizations. There's adverse unintended consequences of hospitalization. So depending on where the person is in the disease progression, having some discussions about hospitalizations. Are they beneficial? Are they not? And then one of the things that people should insist on, if a person doesn't, if the decision is not to hospitalize, what do we do instead? And you deserve to have some action that you as direct support providers have instead. Social interactions. Oh, these are so important. How can we communicate? What's the best way? And there's a lot of dementia capable, the education and training around what do we do to make the social interactions as positive and have them connected and minimize behavior distress? And I'm not going to get into a lot of this because this is all in, you've got that other thing. So as Matt was talking about, it's a continuum. Once a person's been diagnosed, it goes through those stages. And so we look at what can we do and how do we support people throughout this. And things can be difficult at times in terms of people may seem, well, is this stage that they're in or that's not? I think we have to look at where the person is in the moment and what can we do. So looking back on one of the Nancy Yochanan and a group of people developed, it was like community supports for people with dementia, and they'd use some of the stages, and I'm not going to read these, but you'll have these, and these are some of the considerations that you need to kind of think about. For instance, looking at engaging the person in the early stage around planning for things, looking at their routines, how can we look at that, and activities, day activities and programs in terms of keeping the person happy and healthy. The mid stage, looking at, for instance, some of the things creeping into like relationships. How do we keep this? And this stage, there's a lot of intense relationships at that point when you work to support somebody in the middle stage of dementia. I wanted to kind of just call your attention to the point there about medications. Even though we mentioned mid-stage, medications and reviewing medication is important throughout the continuum. I can't help but stress that because meds have a lot of side effects, that the interactions, etc., will really affect the well-being of a person in many ways. And finally, the last stage is something that in terms of, this is the stage, there's a point where you use a lot of durable medical equipment. There's a lot of physical hands-on care. And if you're working in some homes where people aren't used to doing actual hands-on care, they don't know how to do good skin care, etc. These are things that people have to have education around these kinds of things. And also being aware, getting other people in around palliative care and hospice care. These people can be your friends and will help guide you through the process. I've worked with some great hospices that have engaged the other housemates and looking at what can we do to support that person. And, also to be aware of the regulations. I had somebody who did all this education and, it was fine. And then it turned out she was in this accessible house with 4 other people. However, 3 of them needed 2 people to get up, to get out of bed with, lifts, etc. So unfortunately, because of the regulations require with fire 2.5 minutes, the staff could not do this, all with 2 staff on. So they had to do a lot of careful consideration of what next do we do for people like that. But these are things you don't think about and plan for, but think about these kinds of things in terms of keeping a person to the end. Lastly, about planning for dementia, I'm not going to delve into all the details of different decisions that may have to be made. I think one thing is that go back and be informed, and people should be able to weigh the burdens and benefits of whatever decisions. And remember the person, their values, and what's important to them, and they go on to. And then, it is a one-time planning. Looking at, what the prognosis, it's uncertain. Some of the things we try to plan the best we can. We do the best we can. And there might be conflicts and obligations. So we look at our own values, and what we would want if that was us. And sometimes that can be a rub. But I think having the time to communicate and talk about this in thoughtful ways is essential. And because sometimes people may think just because, if you're not giving somebody putting a feeding tube in, is think, oh, that person's not getting, equitable treatment. When we, in some case, what we know from dementia care, that feeding tubes do not prevent aspiration, etc. So there's a lot of discussions, but I'm just saying you really need to have a communication and a thoughtful discussion about this. And then the last thing that I'm just going to put out here is some tools to help you through this. And the tools on the booklets on the right-hand side are from the Institute of Healthcare And they talk about planning for dementia, not for people with intellectual disabilities, but I do think a lot of these guidelines will help us in what we do and support people with the people we work with with dementia. And this last book that I just found, that's part of it, is something that you might be able to do. It's almost like a 5 wishes with somebody around dementia care with some of the people that we support. And so I'm just going to conclude here, developing a plan of care. And it's interesting for me because when I look back, this probably harks back to 1990, 96, 97 after working is, what do we do? How do we develop a plan of care and working together, educating ourselves, a support plan, monitor our feelings, being realistic. And the last thing is that be kind to others, be kind to yourself. And that painting in the background back in 96 talking about things is by Barbara, a woman with Down syndrome and Alzheimer's disease, who used to the staff worked with her. They worked on these great paintings. And so I actually bought a few from her, and and these are things that really resonate with me. So I think using the arts, failure-free activities to help you in terms of supporting the person. So talk about being kind is something that comes out of Maya Angelou. I did then what I knew how to do, and now I know better, I do better. So you all take care and be kind to each other and just support each other throughout this process. Thank you.
Kathy and Matt, thank you so much. Please post your questions in the chat box if you have any. One thing, I'm getting several texts about availability of slides and recordings. We are recording this presentation, and the slide deck will be available, as well as all the websites that Matt and Kathy have mentioned. They will be available and archived in our YouTube channel, and you will get an email once those go up, and we usually do it within a week. And yes, Dawn, you will be automatically emailed the access to the YouTube channel. While I'm waiting for questions to come, thank you so much, Matt and Kathy. One of the questions I had is, could you summarize some of the most successful approaches for people to age in place with their peers?
Kathy, you want to do that? Or
I think some of the things that I think about is always if they want to to age in place is for the peers and people to get developing relationships and talking about things. You can be proactive in talking about with people early on about what it is to age, doing some education around people with intellectual disabilities about what happens when we get older. There's a lot of great resources out there, and having some talks and communication. One of the things I think about too is that people are very sensitive. Your housemates. They know something's amiss or something's going on. I think you need to kind of figure out with the person, the decision maker for an individual, maybe with dementia, about what can we tell the housemates, or how do you want us to handle this? Because people will have a sense, and even if you have to talk about using your human rights committees or people in terms of HIPAA, how do you discuss these kinds of things? One of the things is that and engaging people and being there for people who, the housemates and other people, that it is hard. It's hard for all of us. And, they can be a part of a support group with you all, in terms of your meetings. One thing I did in one of the homes that I was working with is in the house meetings, they would carve out a little portion of the time for like a support group meeting. And then even furthermore, carve out another little point and invite the people who lived in the house. I mean, this is after speaking with the decision makers and figuring things out and going through, human rights, whatever you need to do about these things, and having a support group with the people who are also living in the house. There are ways to figure out with regulations and stuff what you can do to help and support each other. But I think early on, one time we had somebody in terms of aging, we had like a six course training or whatever we went through, in terms of decisions, and we even brought them to the intensive care, or we worked with the hospital and brought them into the room where they had ventilators, etc. So we could do a lot of things like that with people. So I think trying to figure out about aging well, and what's normal aging, what do we do and what can we do to take care of each other through this process?
Yeah, I was just going to add one thing also. If you're talking about trying to explain what's happening to an individual who may be showing signs of dementia for housemates, there's some excellent publications that Down Syndrome Scotland has
Yes.
produced on what is dementia,
Mm-hmm.
using kind of pictograms and easy explanations. And we
Yeah.
have those posted on the NTG website. And
Yeah.
they're
Those are
not very
great.
big. Yeah, they're not long, but they do serve as a good icebreaker when you want to kind of
Right.
discuss it with other individuals living in the home, so they can appreciate what what Jane or John is going through as he starts to act maybe differently.
Mhm.
And they may have some more controls put on the house because they have to watch about wandering,
Yeah.
or they may have to lock some cupboards because he or she may go in and think they're drinking a beverage when it's actually a cleaning fluid or something like that. So those are things that have to be discussed, and so people appreciate what's going on.
Right, right. And they even have, Matt, things on aging too, the Scottish Down Syndrome
Yeah, they do.
Society. They're great, a lot of things. The other thing that writes to dementia right now, there's a program called Dementia Friends, and there's a group, and because I'm sort of involved with that out of Ohio, that have modified that for people with intellectual disabilities. So they were looking at piloting that. But you're right. I mean, there are a lot of things, but I think having a communication and figuring out how you're going to do that thoughtfully, given the auspices of HIPAA and everything like that. But there are ways to figure out and working as everybody, we're all in it together, kind of.
Yeah, one of the questions that's come up is how do you bridge the silos between aging and disability services?
Ooh.
Certainly, particularly if the individual is aging, or they're living with a family that's older, the aging network tends to be the primary provider of some type of supports for older people. And the disability that provides maybe the residential services, which is the primary provider for someone who needs housing, who have an intellectual disability and may be affected by aging. So having those kinds of network discussions between the two systems is a very useful way of providing kind of a package of services to whoever's affected and their caregivers.
Right, right. And there are things even with the Alzheimer's community. I mean, we in Massachusetts, there's this sort of a program called Memory Cafes, and the Mass DDS, the Department of Developmental Services, actually funded a few in terms of making them much more ID friendly. So, and if you go to Memory Cafes and Dementia Friends or Memory Percolator Project, and Yasmin, I could probably send you the information, but you can go online and there's a webinar about making your dementia, your memory cafe, friendly to people with intellectual disabilities. So I think, there's a lot of things like that I think there are some bridging the gap between the silos, between all of these sort of entities.
Thanks, Kathy. I think I just put a link to the Memory Cafe
Oh, good.
percolator.
Yes,
Hopefully
that's perfect. That's perfect. Beth Salzberg's been great to work with on this. So,
any other questions from anyone? We have about 2 more minutes. One of the questions that came through is, have you seen music being included within group homes to help with changes in cognition?
oh, yeah. I mean, well, and it changes the cognition. I think part of the thing for me is that it will also, and after your sense of well-being, but some of the things, it will spark things. For instance, when people were younger, in terms of bringing people back, and it may bring a point of, like, in terms of cognition, an awareness. And I think that's the point of it. And that is, well, depending on where the person is in the process, maybe that's it.
Yeah, the other thing too is that music and singing, for example, singing is one of the last expressive language skills that go
Mhm.
someone's capabilities, and they may not have a conversation, but they will sing a song that that's familiar to them or has been taught to them.
Yeah,
So
yeah,
music is a very effective tool engaging people and
exactly.
engaging memories.
And that's engaging, engage, and then we're engaged too. And that sort of thing, that feeling tone is really communicated, and that is just incredible.
One additional question is, any thoughts or comments on I may mispronounce this, but Sneeuwzellen rooms?
Oh, snoozelen rooms. Yeah. Well, I know the Dutch use that a lot, and they were really a big thing. I think you'd have to kind of try it. It may be, and again, setting one up, etc. But sometimes, and depending on the individual, it may be overstimulation, what's going on. You can, use like what is the snoozelen room trying to do? It's bringing in sensory kinds of experiences, whether it's, lights, etc. And you can even do that on your own with other kinds of sensory experiences, whether it's olfactory and not. I mean, you just have to try it, I mean, for some people it works, and it's kind of, to be honest with you, I haven't followed up recently. Matt, have you heard anything more on the snoozelen rooms?
I know sometimes that you can use them to provide calming and stimulation for individuals. It really depends on where the person is in terms of their perceptive abilities. Whether will it stimulate something that's calming for them, or stimulate something that's anxiety provoking. You have to kind of get a better sense of it.
Yeah, that's the thing. And they can be quite costly to set up. I guess maybe that's the other thing in this day and age. But, I think when you go back to what are we trying to do? We're trying to provide sensory related experiences. And what do we talk about sensory things? Is there anything we can do for the person? And also, if we can also look at who the person is and what's important to them in terms of rooms like that.
Yeah, any kind of brain stimulation is going to be functional. You have to measure it in such a way so it doesn't cause anxiety or disorientation as well.
Yeah, I think that's a good point, because some things might, I was laughing because I just was speaking to a group home the other day, and somebody who was pretty high functioning in her youth, she used to go out to bars and smoke and things like that. So I was saying that now she's in the house and she has dementia. I'm like, well, maybe you can, set up a little social things and have just maybe like a medicine cup full of maybe some wine or a little beer, and pretend, you're out at the bar, in terms of bringing back a memory and talking about, whoa, what was that bar you went to, and blah, blah, blah. It's just things like that, being a little creative in terms of,
you can use grape juice or 3.2.
Yeah, right, exactly.
Okay,
I think we're out of time, aren't we?
we are, yeah.